She has nicely covered all the relevant anatomy and fluoroscopic views, different views. So I'll straight away go to the procedure itself. While speaking on percutaneous microballoon compression, it is one of the safe, effective, and quick way to have ablation of the trigeminal ganglion, but unfortunately it's the underutilized entity, and especially this type of ablation is very effective in patient who have involvement of V1, okay, and the patient who doesn't want any intervention in awake patient, okay, they want good sleep while doing it. In those patients you can use safe reduce, and if patient have multiple intervention, like number of times he has intervened this RFA ablation, so those patients can be effectively treated with this. And one of the most common indication of these is post-herpetic neuralgia, especially involving V1 division of the trigeminal ganglia. Coming to how it's different from other procedure, is the same as other ablative, especially RFA, peripheral rhizotomy. Basically, it's a compression by balloon, and it preserves the ganglion cells. And compression causes ischemic injury, but there is differential injury of axon with superior trigeminal ganglion cells, and that suggests that axonal regeneration possible, and that may contribute the recovery of motor and sensory function in due course of time. And histological studies have found that the injured areas have higher number of surviving small axonal fibers, so that there is a selective preservation of unmyelinated pain responsive fibers that seems to opposite to the other ablative procedure that injure these fibers. And there is a selective preservation of unmyelinated pain responsive fibers seem to be a live goal for the pain treatment, as I told you. And balloon compression relieves trigeminal pain by injuring the large myelinated axon. Those axons are relatively involved in sensory trigger. And unmyelinated pain fibers mediate low receptive pain transit, but they are not the source of sensory trigger. So that way, that is different from the other ablative procedures. It's a simple and effective procedure, usually in multi-division involvement. I told you, especially using ophthalmic division involved. It does not injure myelinated fibers which mediate the blink response. So can we safely use venous division involvement? It's especially useful in patients who have communication problem during selective thermal rhizotomy. Most time by use general anesthesia, the people in literature said that people use in local anesthesia also, and monitoring very important, especially those patients can have trigeminal depressor response that have severe bradycardia, and some patients may have SST also. So you have to be careful. You have to keep the restriction drugs, defibrillators to be standby, and as it's a CM guided technique. We usually use heart rate technique that is described by Dr. Ashish also. In those procedures that we utilize anatomical landmark and fluoroscopy CM views, the position is supine, and one has to be careful there to be unnecessarily hyperextension neck has to be avoided. And three landmarks we use at point of entry needle, like 2 to 3 centimeter related to the external this angle of mouth, then mid pupillary line, and 2-3 centimeter from the mid-zygomatic area. And we utilize direction depth technique. At every insertion, like 5 millimeter or 1 millimeter, we check the different views, lateral views and IP views. And one has to be cautious not to breach the oral, because as Dr. Ashish has described, as regarding this RFA and this position, basically we never insert the needle under sedation. We, as Dr. Virender has told, that we use only local anesthetic to insertion needle till we have lateral view. And if you see this, we keep the needle like this and slowly insert and see the patient response. If patient is having some pain or some paresthesia, we usually counsel that patient, reassure. If even that patient is not cooperating, then rather than midazolam or propofol, I use fentanyl. 20 to 25 more. And after waiting for some time, insert the needle. And how we decide what is the end point of the needle? This is the pituitary fossa, this is the clivus. Where the clivus meets the protruding part of the temporal bone, that is the junction where we should aim this. And if you draw a line from base of the pituitary fossa that crosses the clivus, that's the end point. You should not exceed your needle insertion above this area. That means you are near the ophthalmic division. And at 5 millimeter above that line, that is you are at the V1. 5 millimeter below this line, that means you are the V2, and another 5 millimeter, that means you are near the V3 division. We go with it. And then final is patient response. We estimate and ask the patient where he is feeling the paresthesia or pain. Similarly, and what is different in needle position in PMBC, we never go above this area. Okay, we try to keep the needle tip at the wide bore needle. We usually use 14 gauge needle. We keep the needle here and insert the catheter, and catheter has to be just above that line crosses the clivus. Say 2 to 3 millimeter above this line. I'll just come to that. When we started, I think we started this procedure in 2010, when we started this patient that internationally, that Cook's PRBC kit used to be available, but that was not available in India. So we made some stopgap arrangement. We utilize this type of needle. This is the needle, 14 gauge needle. This needle is basically used for insertion of spinal cord stimulating lead. Okay, and we use this Fogarty 4-inch catheter for conduct of this. Nowadays, this kit is available. This is around 35 to 40,000 kit. It has got all the things and has a pressure monitor also. To start the procedure, I always take AP view first. And if you look at the AP, this is not the AP view. And AP view, I try to keep the petus part of temporal in the inferior part of the orbit. That is a true AP view. And I tilt for some interval till this, you can see this mandible, maxilla, and this is some mental arch. Unless you have this area, this is the bone-free area, then usually 20, 30, 30 days submitting is more than adequate. And once you have that area, then you slightly have a oblique view. You rotate the C-arm ipsilaterally and have, at the focus is always this. You can see this foramen oval. It should be always, if you divide in 4 quadrants, this should be always in the upper quadrant. And as you can appreciate, in this area there is no bone. So you can simply use the tunnel view. You can after this, I always use 2 to 3 centimeter to the external angle, and I always use tunnel view. If especially in RF ablation, if I am planning to do ablation of V3, I always keep the needle lateral or middle if you are planning to use V2 or V3. And for PMBC, I will insert the needle in the middle of the foramen. Sometimes there is an article by Brown that says that if you take it's a true AP view. Now you can, this is the petus part of the temple. If you appreciate the middle part of this, in middle aspect, there is slight dip in the petus part temporal. That's the area where Meckel's cave lies. If you keep the needle laterally, that means you are trying to ablate the V2. If in the middle of this, that means V2 or V3, or medially for V1. As you can appreciate, the tip of the needle is not crossing, not more than 2 or 3 millimeter above the foramen oval, and direction of needle is the point where clivus joins the petus part of the temporal bone. after asserting that is my needle position is okay, I insert the catheter. Initially, we used to use that ureteric catheter to make a tunnel so that we can insert the catheter safely. But over a period of time, we found that there is no need of making any tunnel or channel. You can simply, most of the time, most of the patient, you can simply insert the Fogarty catheter. As you can see, the tip of the catheter is just 2 to 3 millimeters above the point where the clivus meets the pittus part of temporal bone. These are balloon shapes. So once we have confirmed that my tip, balloon tip, this catheter tip position is okay, we try to inflate the balloon. We take 1 ml of operative contrast material, and this has to be done by continuous fluoroscopy technique. Initial picture done after starting the inflation with radio contrast dye. This is then ideal position is this. You can see that the nipple is coming out, and that shows that nipple is going towards the porous trigeminal. That's the ideal. That's the ideal position, so that you can have a good compression of the trigeminal ganglion. Coming to different pictures, if you overinflate, that you can have a dumbbell shape appearance, dumbbell application, and this is more or less ideal position for having ideal compression, pear shape appearance. As I told you, that ideal position is this, 2 to 3 millimeters above the macula. We can see that it's just 2 to 3 millimeters above the point where clivus joins the pittus part. And just to say few words, that catheter should be porous as it compresses the retrogressive fiber against the form as the dura and petrous raises the needle space, allowing nerve to pass in the Meckel's cave. If proximal to porous, if you inflate the balloon proximal to the porous, then the balloon itself lifts the ganglion from the dura and no effective compression can be made. So always you should have a nipple shape appearance so that part of the catheter balloon is in the porous trigeminal. These are various shapes one can. This is dumbbell. This is not effective. This is also not effective. Partially effective. This D is the best. This is going to the cranial fossa. This is also not required. This is another dumbbell shape. So ideal is this small clip. This is how we start the procedure. We usually use anatomical language for initial purpose, then we follow the fluoroscopy guidance totally. And while inserting the needles, as patient anesthetized, there is no need of giving local anesthesia. And before starting, always check and always keep a finger in the mouth so that needle tip won't reach the oral mucosa. Once you stabilize the needle, say 2-3 centimeter, always go for some fluoroscopic use. Because you can say needle is going towards the mid-pupillar line and mid-zygomatic area, and that needle insertion itself is 2 to 3 centimeter lateral to the angle of the nose. As you can see in this view, now just enter the coronal ovale. I will just stop here. And that after confirming the position, I've started inflating the balloon. Now, once you have a pear shape, you keep the compression to initially it's described around 90 seconds, but I keep usually 120 seconds. And after this compression, but during compression also the patient can have trigeminal depressor response. So we have to be careful. Those patients have cerebroidiotic, and in some patients we have encountered a systole also. And some physician recommend use of pacemaker or keeping the defibrillator ready for this patient, because in one of our patients we have a systole, we have to resuscitate the patient, but the patient comes out very well. And once we have made good compression, we have to remove the whole of the equipment, catheter and needle in toto, and give a good compression at the insertion site for at least 5 minutes, so that there is no hematoma formation in the face. Time is over. Can I have 2-3 minutes? And regarding pain relief duration of shape and balloon, as I told you, the PA shape had maximum relief and good outcome. And this sensitive ulcer compression PF shape, it has good compression result in good pain relief in most patient. And avoid the balloon too much in, otherwise, especially if you are having dumbbell appearance, that means you are going towards the cranial fossa. Regarding pain relief, that is most important. And in our study, in our case series, we found that 99% of the patient have immediate pain relief. The moment you shift the patient to the ward, and once the patient come out of anesthesia, they take it patient, they are having good pain relief. And in most of the study, the pain relief is more than 94%. And as any of the percutaneous transformable technique, this patient can have some complication, especially paresthesia or sensory loss in the face and masseter weakness. Coming to masseter weakness is around 70%, 60 to 70% after percutaneous balloon compression. I think this is maximum in this procedure. And some patients may have hypostasis in the face, but usually these things resolve out between 2 to 3 months the patient will have. Thank you very much. Delete.